Yeah,
If you're
so
on the
hello
phone,
everyone. I'm Mike, the OPAGS chair. So I was thinking we can get started. I have the agenda up and then Courtney will kind of take the rest away for us, if that sounds good, Courtney.
Yep, it works for me.
Great.
All right, so we are going to start with just kind of a general overview of the OPAGS board members, and then I'll introduce the speakers, but I'm going to go through that relatively quickly just so that we can allow the speakers as much time as possible to talk. So I am Courtney Young. I'm the diversity co-chair on the OPAGS board. I'm a second-year graduate student at Wright State University School of Professional Psychology. And my clinical and research interests are within children diagnosed with neurodevelopmental disorders. And then we just wanted to orient you to some of the benefits of being an OPAGS member. So those are going to be on the screen. And I believe you will receive a copy of the slides after this if you just want to read through that and see if this is an opportunity you would be interested in. This is Mike, who was just talking. He is the chair of our OPAGS board. He's a fourth-year graduate student at Xavier University, and he's interested in health across the lifespan, and his goals are to pursue a career as a behavioral health psychologist in a hospital setting. This is Lexi. She is our chair-elect of the OPAGS board. She's a third-year student at Case Western. And she is interested in anxiety and related disorders in children and parents and how that would impact family functioning. This is Jessica. She is our continuing education chair on the OPAGS board. She's a third-year student at Wright State, and her clinical interests are on children with chronic illnesses, pain, neurological disorders, cancer, medical trauma, and emotional disorders. This is Devin Douglas. She is a fourth year at Wright State University, and she's our advocacy chair. She's interested in working with forensic patients who are diagnosed with severe and persistent mental illness. And this is Sarah. She is our social responsibility chair. She's a third-year clinical psychology student at Miami University, and she is interested in the cognitive, emotional, and psychophysiological processes that maintain anxiety and obsessive-compulsive spectrum disorders, and then the role of positive emotions in psychopathology. This is Sarah Love. She is our science and technology chair on the OPAGS board. She is a fourth-year student at Wright State University. And after she finishes the program, she hopes to work as a pediatric psychologist in a children's hospital. This is Brant. He is also the diversity co-chair with me, and he's a second-year student at Wright State University. He is interested in pediatric neuropsychology, neurodevelopmental disorders, and traumatic injury. This is Emily. She is our communication and membership chair. She's a third-year student at the University of Cincinnati Clinical Psychology program. And right now, her clinical placement is at the LEND program at Cincinnati Children's, and she does evaluation for children with various neurodevelopmental disorders there. And finally, this is Anthony. He is also our communication and membership chair on the board. He is a graduate student at Farley Dickinson University, and he is interested in providing therapy and conducting assessments for children, adolescents, and adults. So the whole age spectrum as well. And this slide has the various OPA campus representatives in case any of you are from these schools and want to reach out to them and ask about any other information about OPA. These would kind of be your go-to people.
Thanks.
So if you have any questions that you think of during the presentation, we're going to use the chat feature. So you can post your questions in the chat. That way you don't forget about them, and we can make sure we get your questions answered at the end of the presentation. Okay. So we're going to be talking about prescription privileges for psychologists. So I'm going to just briefly introduce the speakers to kind of orient you all to everything that our speakers have done throughout their careers, and then I will hand it over to them for the rest of the presentation. That's just another picture of me. All right, so our first speaker is Jerry Strauss. So he is a retired clinical health psychologist with over 30 years of experience in behavioral medicine and health psychology. His primary clinical responsibility while on the faculty with the Cleveland Veteran Affairs Medical Center was in the outpatient medical clinic. Dr. Strauss was the section chief of clinical health psychology and the director of health psychology postdoctoral residency program before retiring from the VA. He also served as the Health Promotion Disease Prevention Program Manager for the Cleveland Clinic VA Health System. Dr. Strauss is an assistant clinical professor of medicine at the CWRU School of Medicine. He remains on the faculty at the School of Medicine and is a member of the IQ leadership team, the Professionalism Working Group, and the Physician's Assistant Program Advisory Board. He holds a degree as a physician's assistant and previously practiced in the field before graduate school. Dr. Strauss is a past president of the Ohio Psychological Association. He is known as the grandfather of the prescription movement in Ohio. In his retirement from an academic medicine career in psychology, Dr. Strauss is now a commercial helicopter pilot. Okay, and our next speaker is Dr. Marlon Hoover. He is a licensed psychologist in Illinois and New Mexico. Dr. Hoover is board certified in clinical psychology by the American Board of Professional Psychology and in medical psychology by the American Board of Medical Psychology. He is a fellow of the Academy of Clinical Psychology and a fellow of the Academy of Medical Psychology. He earned a PhD in behavioral sciences from the University of Chicago and a postdoctoral master's in clinical psychopharmacology from Farley Dickinson University. While starting a private practice in the Chicago area in 1985, he was a faculty member of St. Xavier University for 20 years. And chair of the Department of Psychology of St. Xavier University at Chicago. He has done research and publications on the relationship between personality and heart disease, training of psychologists, and validation of personality tests. And our final speaker is Dr. Brad Potts. His career and beliefs center on public services, starting with his education in political science and economics from Bowling Green State University, serving as a congressional intern and page at the Ohio Senate to work with the Ohio Public Utilities Commission working on consumer issues, energy conservation, and nuclear safety. Public service has been his focus. He earned a master's in counseling from The Ohio State University and doctorate in counseling psychology from the University of Akron, studying optimism and cardiac rehabilitation. During his APA internship at the VA, he obtained clinical experience in psychiatry, health psychology, and neuropsychology. In July of 2000, he joined the Ohio Department of Rehabilitation and Corrections as a psychologist supervisor, providing clinical and administrative supervisory in 4 facilities, overseeing the care of hundreds of offenders. He became involved in OPA in the spring of 2001 and was appointed to the Board of Governors as the chair of Advocacy Committee in 2011. In that same year, he joined the Attorney General to chair the task force on criminal justice and mental illness. And in January of 2013, he was asked to be the vice chair of the Committee on Psychiatry and Treatment. He is a licensed independent chemical dependency counselor. He earned his Master's of Science in Clinical Psychopharmacology in 2017, and he passed the PEP in November of 2018. He is currently working with Angela Miller, Michael Rainey, Jerry Strauss, and Kristen Brinkleman on prescriptive authority legislation for the state of Ohio on behalf of OPA. So that is just a brief overview of our speakers, and then Sarah and Jessica will be handling the Q&A session. And then just a reminder for all of you that the poster session application for the OPA conference in April is going to be next week on February 22nd. So if you have not submitted for the poster session, don't forget to do that. All All right, and now I will hand it over to our speakers.
Okay, I guess I'm first up. Thank you. So this is Jerry Strauss talking. Can you hear me all right? Everybody good? Okay. So I want to first thank OPAGS, the chair, and all the board members there, and also thank Michael Ranney, the CEO of OPA and OPA, for allowing us to talk this morning about RxP. So because of my age, I'm supposed to talk about the history of RxP. So usually in history, you read about it. Well, I've lived it. So you're going to get a firsthand overview of what we've done. I'm going to start nationally to give you some context, and then I'm going to hone it down to what we've done in Ohio, okay? So next slide, please, thanks. So some important events that have happened. So in 1985, Hawaii, the Hawaii Psychological Association was the first state to introduce a bill for prescriptive authority. And part of the reason Hawaii was the first state was because of a gentleman called Dr. Pat DeLeon, who is the grandfather, the great-grandfather of RxP in the United States. So I'm going to be coming back to talk a little bit more about Pat as we go through the slides. And I just want to say it was really fun pulling out my old papers from years and years ago, because it included some nice handwritten notes when people used to actually write handwritten notes from Pat and some other people that started the RxP movement. So then in 1991, the Department of Defense psychopharmacology demonstration project began with 2 Navy psychologists. And again, Pat is the one that set up this program. And I've got a little sidebar story to tell about the DoD program. So it's 1990. I'm watching the Final Four basketball games on a Sunday afternoon. The phone rings. My wife answers it, and she says, "It's for you." I said, "I'm watching the ball game. Who is it?" She says, "I don't know, some guy named Pat DeLeon." So I'm thinking, oh my God, what did I do? Why is he calling me? And so I get up to the phone and I say, "Yes, sir, what can I do for you?" He says, "Jerry, I understand you're interested in prescriptive authority." I said, "Yes, sir, yes, sir." He says, "Here's what I want you to do." Now, mind you, Pat is a man of few words. So he gets right to the point. So he says, "I need you to move to Washington, D.C. I need you to join the Navy. And then I'm going to enroll you in this demonstration project that we set up to teach you how to prescribe psychotropic medications." Well, my wife and I had just built this house and just moved in. So I said, I got to talk to my wife about this. So we did speak. And I called him back later that afternoon. And I said, "Thank you very much for the offer, but I can't do it right now." So I've done a lot of things in my life, but it's probably one of the few regrets that I have that I didn't participate in that program. So moving on to August of 1995. So the APA Council votes to adopt a resolution on prescriptive authority for psychologists. The other thing they did during that meeting was that they started to recognize that psychologists were, quote, healthcare providers. Now, using that term became very important because it puts us on the same level as other healthcare providers. So physicians, nurses, NPs, PAs, and so forth. That meeting in August of 1995 was a pretty contentious meeting. There were a lot of psychologists at that time that were pretty dead set against this notion of prescriptive authority, and they were concerned that if professional psychology went down that rabbit hole, that it would, quote, medicalize psychology, and they were deathly afraid of that. That has not happened to date, and I suspect it won't happen. Next slide, please. All right, some more important events. So in August of 1996, APA Council approves model legislation for prescriptive authority training programs. Now, there had never been a discussion about how many hours, whether it be semester hours, contact hours, or whatever, regarding training. But APA at that point came up with 300 contact hours as a minimum for any training program that was going to be developed. So keep that number in mind, keep 300 in mind, because I'm going to come back to that in a future slide. So then in June of 1997, the fourth and final DoD demonstration project class graduates. So there were 10 military psychologists that graduated from that program. And because they were still in the military, they continued to write for prescriptions for psychotropic meds in the clinics, on base, and even when they were stationed overseas, they continued to write for psychotropic medications. Now, once that program was completed, they had to evaluate it to see, was this a reasonable thing to do? Could psychologists be trained to do this thing? Well, the Government Accounting Office and an internal audit from the DoD and an external private company also did an audit. And they all came to the same conclusion that psychologists clearly could be trained to do this, and they could practice and prescribe safely and effectively. And that's an important consideration, because every time I have given testimony at the State House about various bills that we've had, I've always discussed the DoD demonstration project and its conclusion, the outcome that psychologists could prescribe, excuse me, safely and effectively. So we keep coming back to that time and time again, even though organized psychiatry is saying that psychologists will kill people if they're allowed to do this. So then moving on to August of 97, APA Council authorizes the college to develop an exam. So for people that have gone through training programs, there needed to be an exam that states could use to determine if they had a certain level of competency to prescribe. So this was the PEP, the first PEP exam. PEP is Psychopharmacology Examination for Psychologists. So I believe that's being revised right now, and I think Dr. Hoover is on that committee that's revising it. So next slide, please. So December of 99, the territory of Guam passes a collaborative practice act. And there were 2 psychologists working on the island of Guam at that time. And what this limited prescriptive authority for them was that they could not write the initial prescription, that had to come from a physician, but they were allowed to either increase or decrease the dose or discontinue the medication without a cosigner. So that was one of the first things that happened. And then in September of 2000, APA College of Professional Psychology's psychopharmacology exam, so the PEP, became available for states to use. So from the time the APA decided we needed an exam, 3 years later, it was pushed out and states were allowed to use it. So the curious thing about this examination, it was developed by prescribing psychologists, physicians, some psychiatrists as well, PharmDs, which are clinical pharmacists, nurses. So it really was a diverse and multidisciplinary effort to develop this examination. And then in 2000, the APA Division 55 was established. And I'll talk just a little bit more about that in the next slide. So go ahead, next slide, please. Well, maybe a couple slides away, I'll talk a little bit more about that. So the next 2 dates that come up, so 2002 and 2004, are really important. So these were the first 2 states that passed laws allowing psychologists who have been trained and who have passed the PEP exam to prescribe psychotropic medications. So the first was in March 6th of 2002, that was in Mexico. And then the second was Louisiana on March 6th, or May 6th, sorry, of 2004. And then, so the interesting thing about 2004 is that APA had its convention in Hawaii that year. And I remember being there, Michael Ranney was there, There was a lot of handshaking and hugging and backslapping because now there were 2 states that had passed legislation. And so now the other states are going to fall like dominoes, and every state will have it. So we thought at the time. It's been a bit slower than that, a bit slower than what we had anticipated. So then a couple years later, a few years later, in January of 2005, both states, New Mexico and Louisiana, allowed their regulations for prescribing to take effect. And then since that time, there have been over hundreds of thousands of prescriptions written, not only in Louisiana and New Mexico, but other states that have passed laws as well. And as far as we know, research that we've done, not one malpractice case has been brought against any prescribing psychologist. So it goes back to the notion of being effective and safe in prescribing these medications. Next slide, please. So here's the slide I was going to talk about Division 55. So many of you, as I know this morning now, are going to school at Wright State. And Ron Fox, he is probably second to Pat DeLeon, the second one most responsible for RxP in this country. So Ron Fox founded Wright State School of Professional Psychology in 1979. Those of you that go there probably know that. And he envisioned, when he founded Wright State, as a school where you could also go and get trained to become a prescribing psychologist. That never happened, unfortunately, for various reasons, but that was his vision, and I wish that would have happened. So Ron was also the president of APA in 1994, and then was the senior advisor and convener of the Blue Ribbon Panel to propose training for psychologists to prescribe medications. So that, remember that 300 hours I asked you to remember, he was a big part of that and rolling that training model out. He also founded Division 55, which is the American Society for the Advancement of Psychotherapy. So many of you may be on that website from time to time reading news about new and upcoming things. He also wrote a number of articles. I just have one listed here, but he wrote a number of articles about RxP, the history of it, and so forth. And unfortunately, Ron died March of last year, which was a big loss to professional psychology in general, and for those of us interested in RxP. The other thing about him, in the 1990s, he was advocating for integrated and collaborative care. And Ron and I had a number of discussions about this. And so when I went to the VA in Cleveland, I started psychology in primary care medicine and followed that track. So it truly was a collaborative and integrated effort. So next slide, please. So other notable leaders in the RxP movement. So I mentioned Pat DeLeon, who is not only a psychologist, but he's got a master's in public health, and he's also an attorney. So he was the former chief of staff to Senator Daniel Inouye. And that's how a lot of things started in in Hawaii. So that's why Hawaii had the first bill introduced for RxP. And then it just moved on from there for Pat. He was also past president of the American Psychological Association in 2000. Another interesting fellow is Dr. Sam Feldman, who started the first training program for civilian psychologists to prescribe medications. So Sam was starting the Prescribing Psychologist Register, the PPR. And I've got a little story that I will tell in a bit about that. And I'm not going to go through all of these names just in the interest of time. But down at the bottom, you'll see Morgan Salmon's name. And Morgan was one of the first 2 Navy psychologists that graduated from the DoD project. Morgan is now the executive officer of the National Register for Health Service Psychologists, and at one point was dean of Alliance School of Professional Psychology because of his background with prescribing and so forth. So Morgan's a really important guy, and he'll pop up in a couple of other slides. So next slide, please. So we're going to move now from the national level down to Ohio. So the prescribing psychologist register training that I mentioned that Sam Feldman started. So there were 4 of us in Ohio that went through this training, and we didn't know we were going. So sometimes we would fly out to Philadelphia, sometimes New York City, and this would occur every 2 months. So the last number of training sites, sessions that we had were in New York City at the Marriott at the World Trade Center when that still existed. So at one point during a break, I got up and asked to use the microphone and asked if there were any Ohio psychologists there. And there were 3 other guys that raised their hand. And so I said, let's get together for lunch. So we did and talked. And so the other ones were Chip Kobe, David Deal, and Jim Helmuth. So once we got back to Ohio and we finished our training in 1997, we thought maybe we should start an organization. So we did, the Ohio Prescribing Psychologists Association. Now, remember I asked you to remember those 300 hours that APA had set out as the minimum? Well, we had finished our training. Unfortunately, the PPR program was only 150 hours. So instead of being done, we were halfway done with training. But nevertheless, we started the OPPA, and then we thought it might be a good idea to have an affiliative relationship with the Ohio Psychological Association. So we developed that relationship. I think we had to get 25 additional psychologists to join our organization, OPPA. And then I became the representative from OPPA to OPA from 2002 to 2003. Also during that time, I was wearing 2 hats. So not only was I on the board of directors and president of OPPA, but then I became chair of the OPA task force on prescriptive privileges from 2000 to 2002. As that evolved over time, and then we rolled all of our membership and any money we had over to OPA. Then I became chair of the OPA RxP committee, which became known as the task force, and held that position from 2003 to when I retired in 2016. So from that point on, Angela Miller is the RxP task force chair. Next slide, please. So OPA was early on in 2000, they were a little slow to adopt. The board of directors was a little slow to adopt the notion of RxP. So we persisted, those of us in OPPA persisted and tried to encourage them to take this on. So one of the things we did, and I have to thank Michael Ranney for this tremendously. So OPA wrote a grant. So Michael wrote a grant from APA and procured a fair amount of money for us to do a survey. So we developed the survey. One of my interns at the VA at the time and myself wrote the survey. We got some other feedback from OPA board members. OPA sent it out to 4,000 psychologists in the state, and we got 600 responses, which is pretty good. And overall, OPA members were highly supportive of this initiative and moving forward with it. Now, mind you, at that time in 2000, I think the average age of a psychologist in Ohio was probably early to mid-50s. So many of them weren't interested in going back to school per se, but they were interested in doing whatever they could, maybe putting up some money for lobbying purposes and so forth. So then in March of 2000, I was asked to come and present to the board of directors of OPA to talk about RxP in general, strategies that we might need to implement, what training would be entailed, how the survey was going, and answer any other questions. And then about a year later, in 2001, I received a letter from Dr. Kevin Arnold, who was the OPA president of the board at that time. And the letter suggested that OPA's board is supporting the education components of prescriptive authority. They said that we should follow APA's guidelines and so forth, and that OPA welcomes any educational program that meet the APA standards, and that they were asking OPPA to continue the efforts to find educational programs to bring into the state. So eventually they were thinking, okay, we'll take on the issue of training psychologists, or at least providing a forum for them to come in and lecture to Ohio psychologists. Okay, next slide, please. So in January of 2001, Sam Feldman wanted to bring PPR into Ohio as kind of the only training program. And that was not well received. You know, we were going to bring in whatever training program was available and up to standards to APA. So anybody that wanted to go through Sam's program could, but they probably would need to go out of state to do it. And then in May of 2001, David Deal, one of the other board members on OPPA with me, started to move around the state to give lectures about RxP and what it entailed. So our first lecture was in Toledo. And then finally, in 2001, Morgan Sammons came into Ohio to present at the OPA Spring Convention, and that was very well received. Next slide, please. So in 2002, I started discussions with Ohio Northern University School of Pharmacy. So Don Stanslowski was the dean of the school, a registered pharmacist, and John Stanovich, I think, was the assistant dean at the time. And they were developing a web-based program for pharmacists that wanted to go back to school but not have to travel to a brick and mortar place if they wanted to get their PharmD, their clinical pharmacy degree. So they already had something in the works. And so when we presented to them, they thought, well, maybe we could do the same thing for psychologists, develop a web-based program. And they did, and they actually came down to one of the OPA conventions and presented this to us. And we were ready to roll it out, and then some political intrigue happened at the School of Pharmacy, and the wheels fell off and it just stopped. We found out later that both John and Don had moved on from Ohio Northern, and I'll tell you about that in a second. So one of the Ohio Northern graduates, Dr. Matt Fuller, who's one of my colleagues at the VA, is a clinical pharmacist. And so Matt and I started to do workshops at OPA conventions about psychopharmacology. And they were always packed and always well received. So people were really starting to get interested in this notion of psychologist prescribing. And in 2015, Alliant University still has a program up and running to train psychologists in psychopharmacology. So I approached them and asked them if they could provide training for any psychologist in Ohio that maybe wanted it. And then I also asked if they could give, if we could get enough people, would they be willing to give a discount on the tuition? And they said, yeah, that would be fine. So I think we had 25 people to begin with. Eventually it was down to 22, which is the number that Ohio Northern, or Alliant, said they wanted. Eventually, when people had to fork out money, it went down to 8. But thankfully, Alliant was willing to maintain their agreement to give a discounted rate on the tuition. So currently, we have about 20 Ohio psychologists that have a master's degree in clinical psychopharmacology. So remember when I said that John Stanovich and Don Stanslowski moved from Ohio Northern? Well, they moved to the University of Findlay, and they developed a new school of pharmacy there. They kept all their data on how many students they would need and the web-based program and so forth. So we've been, folks at OPA have been in negotiations with them. And as soon as a bill is passed here in Ohio and entered into law, Findlay will start its school of training for psychologists in clinical psychopharmacology. Next slide, please. And then legislation in Ohio. So back in 2010, the governor of the state was Ted Strickland, and he was in office from 2007 to 11. And Ted was a psychologist, still is a psychologist, and he worked in the prison system. So we approached him and we were kicking around some ideas of what we could do in terms of initiating a bill. And so what came out was this prison RxP demonstration project. We got Senator Bill Seitz to sponsor the bill, and the plan was that there would be 6 prison psychologists from the Ohio Department of Corrections. They would get their master's in psychopharmacology, pass the PEP exam, and then be able to prescribe in the prisons. And then we would collect data to see how they did. As time went on, we actually pulled the bill because of actually a lot of the legislators that we were talking with and lobbying. They said, why are you guys shooting so low? Why don't you open it up and make it open to all psychologists? We weren't doing it at the time, and I think we thought better of that later. So we were flying under the radar for a bit, and then in 2016, we developed another bill with 2 sponsors. So Senate Bill 300, again, Bill Seitz, Senator Seitz was the primary sponsor, and then David Burke, also a senator and a graduate. He was a pharmacist. He graduated from Ohio Northern. They were co-sponsoring our bill. And it was doing well. We had lots of interested party meetings with psychiatry, with the medical organizations and so forth, but it never got out of committee. And then in 2017, we introduced House Bill 326 because former Senator Seitz was now Representative Seitz, and the second sponsor was Teresa Gavarone, also a representative. So that bill, we gave testimony multiple times to the House Health Committee, and we probably got farther with that bill than any bill prior to that. Unfortunately, the General Assembly came to a close and it had not been voted out of committee. So we will be introducing another bill sometime shortly, and it may go back to the Senate side. We're not quite sure yet, but we'll see. Next slide, please. All right, so last slide, some additional notables here in Ohio. So first and foremost, I want to thank Michael Ranney for all he's done for us. He does so much for OPA in general, but for the RxP initiative, hats off to Michael for writing all those grants that you did and all the telephone calls and so forth. Dr. Bobby Celeste, former OPA Director of Professional Affairs, also did lobbying, as with Michael. Penny Tips was our lobbyist for many years. She knows everybody in government in Columbus. Just retired as a lobbyist last month, so she will be missed. Dr. Brad Potts, who's going to be talking next, who is the OPA's Chair of Advocacy. What a go-getter. He's the Energizer Bunny. He just keeps doing it. Dr. Angela Miller, I'm sorry I misspelled your last name, but it is Miller. She is now the OPA RxP Task Force Chair. And Dr. David Hayes, former OPA President twice, and he's the OPA all-around utility player. He has been OPA's representative to the APA board for many, many years. And Dr. Alice Randolph, former OPA president and former president of the Ohio State Board of Psychology. She's still on the board, but isn't president anymore. And she also is a prescribing psychologist. And one final person I didn't add to the slide that I was remiss, Dr. Ron Ross, the executive director of the Ohio State Board of Psychology, has been a real support in our efforts to get a bill passed here, which we will. All right, that's all I have to say. That's the history lesson for today. And thank you very much.
There we go. Hello. Time for the Energizer Bunny. My name is Brad Potts. I am the current RxP, well, I'm the current advocacy chair, but also working with Angela on RxP. I'm going to take you through what we did in Lion on the training, the PEP exam, and kind of where we are now with the bills and kind of the process. I was a former OPAGS rep at my University of Akron. So I'm really thrilled that you guys have done this and you're taking time out of your schedules to do it. If we can go to the next slide, we're going to go through some of these quick. OPA knew from its previous legislative efforts that they wanted so many people trained if we're going to do a bill. They wanted, every time we'd meet with them, when Jerry was talking, they would ask, well, how many people do you have ready? And we had people ready, but Jerry knew we needed more. So he started talking in 2014 to put this cohort together. And then in 2014, we entered into an agreement with them and we started our group. Next slide. Next, thank you. The master's program is set up to be 2.5 years. It ran from January 15th to August 2017. Met every third weekend. Classes were Saturday and Sunday. 9 to 12 p.m. Pacific Standard Time, 1 to 4 p.m. So that was basically 12 to 3 in Ohio, 4 to 7 p.m. We used something called Moodle software, which was our platform for the course material grades, our account information, everything. It was kind of like our online university. And then we used a software called Blackboard for the actual online classes. And it was kind of cool. It worked pretty well. And it also recorded everything so you could go back, and that was useful, and I'll show you where. The first year was spent on foundations in science. Now, I'm a guy who had, as they said in my intro, my background was political science and economics. So I was not a guy with a strong science background going in this program. We started in the psychopharm stuff in the second year, and you'll see that. Next slide. I put in a few things to make it interesting. So the first year was biochem, neuroanatomy, neuropathology, neurochemistry, neurophysics, clinical medicine and pathology, physical assessment, and pharmacology and clinical pharmacology. Okay, some people, you saw the numbers went from 22 to 8. What happened, some people found the biochem, I think they got a little intimidated. And what happened is, you find in your first class, they start using terminology. Well, what you saw there was we do 3 hours, take an hour break, 3 hours, and the next day you do it again. So in your first weekend, you do 12 hours of class. So you're going to be picking up terminology in that first weekend you're using as you go through those 12 hours. And what I just happened to stumble on, I just happened to have the following week, my schedule was in the evenings. And so I just got up each morning and I replayed it for 2 hours each day, wrote down the terms, stop and went as I went through it, and it made perfect sense to me. It wasn't that hard. I think other people got a little intimidated by the terminology and they thought it was hard. I actually thought the biochem course was incredibly straightforward and basic and good. I enjoyed it. Then as you see down the bottom, you get into pharmacology and clinical pharmacology. And this is about just the body processing medications, pharmacokinetics and pharmacodynamics. Kinetics, what the body does to the drug, and then pharmacodynamics, what the drug does to the body. I hope I didn't flip those. Marlon will correct me. Next slide. Then we get into our second year. Our second year got into the advanced psychopharmacology, where you get into individual, we did a full 12 hours of lecture on depression and on schizophrenia, on molecular nutrition, bipolar, anxiety. And we went through all these areas you see here. And it was fascinating work. The ethnicity got down there. We had Ruth Rowe Navardi from Pat Air Force Base down in Dayton, because she's the only active prescribing psychologist in Ohio, because she prescribes the right PAT, and she taught that course. We had a fascinating guy for chemical dependency. And for those of you who have never done an online format, I actually enjoyed it. I actually got to know my professors. I had professors who actually sent me stuff out of class and asked me to take a look at it and send it back to them because of some project they were doing on the side. And I kind of developed relationships with them. So it was interesting. I didn't expect that. Next. So cohort 9. So here we go. So then we get into the end of it, which was the research, ethics, psychotherapy, where we look at how, psychotherapy and pharmacology and what the research tells us. And at the end, you do a case seminar. And those last two things were done with Morgan Salmon. And then we had a capstone exam where we reviewed everything in the program. Now, I put this, the Dunning-Kruger effect in, because the question I assume you guys are going to ask yourself is, well, how much do you know when you finish this, and how confident do you feel? Because this is going to become relevant later. Well, when you're first starting out, I think a lot of us as prescribing psychologists, we're kind of taught, well, you're supposed to screen for co-occurring medical disorders and all these things. But we never get the training to do that. Well, you go through this program, you're going to get that training to start to understand it. So what you'll find is initially you're way up here. You may have more confidence without a lot of experience in pharmacology. And as you go through the training, you're going to start to realize there's an awful lot you don't know. And you start to get down here, and you start to realize how much there is to know. And there is a lot to know. I found it manageable. I found interesting. Again, I was not a guy who is well-versed in the sciences, and I was fascinated by it. And then I'm going to show you where you kind of start to pull up and come up, and you start to gain that experience and confidence. And you do, and I'll show you where. Next. So they have the PEP exam. Now, the initial PEP actually expired a year ago. In March of 2017, but they had it ready to go again a year ago, in March of 2018. They had what's called a beta test, and people could do it. And then some of my people did it, my group. I ended up taking it this November, and I got an 83. You need around 70%. You have to pass. Over the next year, the administration of the exam was transferred from APA to the American Association of Psychological and Boards for states and provinces. I'm butchering that a little bit. Someone will correct me. But basically, it got transferred to the association that's over all state and Canadian province licensing boards. So it's more independent now. It's not under a professional association, which is better. It's a more objective way to have it set up. The test was updated to better reflect the actual practice of psychopharm. There it is down here. The Association of State and Provincial Psych Boards. The test is 4 hours. It's 200 items. It covers 10 areas. I put down a link there for you. Flip. Next. I think the questions are challenging and well written. They're integrating material from multiple areas: physiology, pathology, pharmacology, clinical psychopharmacology, research methods, professional issues, and ethics. Okay. It was interesting. I thought it was a very well written exam. Next. It covers these 10 areas. And I'm not going to get into all of this. I'm putting some of the stuff I put in so that you guys have this for later. When you print these off, just you've got to go back to, but you can see where we put the emphasis. There's a lot on nervous system pathology, on physiology and pathology, as there should be. Then you get down there and you see, then you got differential diagnosis, pharmacology, and clinical psychopharmacology are some of the bigger sections. Next. Can you pass this? Well, I think if you prep, you will. I found for myself, I kind of know my own pattern. My own pattern is I have to go through all my material a good solid 4 times. And it's when I'm going through it that final time and I'm integrating and I'm making all those connections and I'm seeing how everything relates to everything else. And I'm starting to have all those little ahas. When I do that, I know I'm ready. And that's what I did. And I did well on that exam. So I think it's manageable. The previous PEP, there were some issues with it. There were some issues with the pass rate. It was probably too heavily emphasized in neuropsych, and Marlon had some things to do with helping reshape that. Next. Okay, does your master's prepare you for the PEP? Well, everything you need to know to pass the exam is in your program, but it would be a mistake to think you're ready when you walk out. Okay, passing the PEP requires the ability to understand and manipulate and integrate multiple areas, which takes a lot of review. So you're going to have the building blocks material you need, but you've got to take and work it over and work with material. Next. So when I was talking to you before, things you need to know as you go through it, I really think it's the preparing for the PEP that starts to bring you up and starts to make this sense, because it's the forcing yourself to sit down and go through and prep this material. APA is looking at making a specialty in psychopharmacology that you can get whether you're independent, whether you're certified to prescribe or not. And I've argued that passing the PEP should be part of that standard. And I really think anyone who goes through and gets the education, you really want to take the PEP as soon as you can, whether your state's passed it or not, because I think that the preparation for taking the PEP is part of the professional development. It really does help you a lot integrate material. Next. So how do you review for this thing? Well, you're going to have your course notes, practice exams, handbooks. There's a handbook of clinical psychopharmacology by Muse and Moore. It's a little bit older, but it's a good foundation piece, and it's got a computer disk in the back that has a practice exam. It doesn't have the answers, so the beauty of that practice exam is you can take it multiple times and use to gauge yourself and how well you're doing. Then there's also review sessions with Judy Steinman, and also a comprehensive PEP review program by Dr. Marlon Hoover. Next. Practice examinations are also a big part of this. Dr. Hoover provides some of these. There's the one I mentioned in Muse and Moore, but we also use the same prep exam books that psychiatry uses. And this is one of them that I found very helpful. Psychiatry's prep exam book by Spiegel. In fact, I never used the book. I just ended up using the software that I got with it. And it lets you take practice exams. It lets you review them. It gives you explanations for each of them. It has a couple different modes you can use. I found that to be a really helpful thing to help prep me. And I would do those, and then every so often I'd go back and take the Muse and Moore and see where I was. And it's when I started seeing my score on that Muse and Moore rise and up to 76 and higher that I knew I was ready. Next. I wouldn't do it alone. I personally went through my doctorate with a group of friends. We kind of met and would get in study groups, and I think that helps on the PEP. And there's a way to do that. Next. So Dr. Judy Steinman is the current president of APA's Division 55 and a former pharmacological researcher, pharmaceutical researcher. She has a program that's ongoing. Classes are out of her residence in Hilo, Hawaii. We were talking to her after and actually while earthquakes were going on, aftershocks. But she would always have great stories, and she's been involved in this for quite some time. I'm trying to remember that program out there, but she'd been involved in the Hawaii program, and she's currently involved in the 3 bills submitted in Hawaii. Classes go a lot deeper into the biochemistry of it. I really almost thought her program was like taking another course in biochemistry, and it was interesting. She really takes time to teach it. She really takes time to kind of tailor it to where individuals are at. She'll offer individual tutoring. Judy's offered people to meet with them as many times as they want right before they take the exam. She really is committed to this. Next. Dr. Marlon Hoover. Now, Dr. Hoover had a PEP prep program for the previous PEP, and then he was asked to help structure this one. He was offered to write questions, but declined to do it because he didn't want to invalidate the PEP. Of course, Marlon is the 7th person licensed in the state of New Mexico, and he helped design the exam. It's a structured one that goes along the blueprint of those 10 areas you saw earlier. So it's 12 sessions. It focuses more on practice. Marlon gives you a ton of reference material. I have a notebook sitting over here that's a couple inches thick of everything Marlon gave me that he uses for practice. Quite frankly, I found them both very helpful. And I did them both. And then you have peers you're doing it with, and it kind of helps to go along with people. At least that's what I found. Next. So where does that put us in Ohio, the trajectory in Ohio? Well, you're going to finish your PsyD, PhD, you know, those of you at Wright State and Xavier and people at BG and our other PhD programs around the state, Akron, where I came from, Ohio State, OU, etc. You get licensed, practice, and then we have some science prereqs that came into this bill. I'm going to show them to you. It's most likely those are going to be in the subsequent bill. The master's, PEP exam, field experience all add up to about 5 years. So it'll take you a little bit, and you're going to be practicing for a while before you finish all this. And we think that's good because we want you to get some good ground experience being a psychologist first. I think it'll help you. Next. This is what we went through in House Bill 326. Now, I sent a summary to Mike and to Alexa, and it's the end of the year summary I wrote for OPA, and it tells you everything we went through last year. We had 6 hearings, 4 days of testimony, 3 days contained proponent testimony with the sponsors, then 1 day, and then 3 days were us testifying. The opposition only testified once, and then another time presented written testimony against it. We were doing rather well. The chair himself made 3 substantive amendments to the bill to improve it. I'll show you some of that. Nevertheless, what happened is we got to the end of the year. We went into a lame duck session. There was the election, and we just weren't able to get to a vote. We knew that we had at least 8 of the 19 health committee members were yeses. 7 were undecided, and 4 were definite no's. We had a pretty good feel that if we had a vote, we would have come out of committee. But the lame duck kind of gets bogged down in all this last-minute political jockeying, and we weren't at the top of their list for agenda items. Next. So here are the amendments that got added to 326. 6 science courses as prereqs. We're going to take a look at that. We added a collaborative agreement. We knew we would always have this. We just left our initial bill kind of open so that we could kind of negotiate as we went. We added having a physician to the psych board. This is because the opposition kept trying to get us under the medical board, and we didn't want to do that. They added requiring the governor to consult with the medical board before appointing a physician. That's almost meaningless because he would probably do it anyways, and he's not required to go with their choice. but it was something someone wanted, so we did it. There was a slight change in the voting procedures, just because the physician would then have to be in the majority on anything that was a pharmacology vote. We removed the use of opiates. We only had opiates for one thing, and that was for opiate addiction treatment, which would have been bupropion. I'm sorry, I'm not saying it right. Buprenorphine, not bupropion, or Suboxone. And we put in some additional training, supervision, and requirements for those who are under age 18. Next. Current legislative status. Following the 2018 election, the House changed a bit, and they had been having this battle on who was going to be Speaker. And they recently just elected Larry Householder, who had previously been Speaker. Now, Mr. Householder is kind of a known thing. The Republicans, it's kind of funny to watch the way they're kind of divided, but nevertheless they were. And so he used Democratic members to help get elected. And because of that, they've kind of worked out some concessions, and they've been taking a little slower to start up as they kind of rewrite some rules. They just, this week, we found out who they appointed committee chairs. And we just had a meeting Thursday with Michael, Jerry, Angela, and we talked to our new lobbyist, Kristen Brinkman, and Kristen's going to be meeting with the chair and some other people to discuss introducing the bill. And so we'll look at whether we introduce the bill in the House or Senate. We've done it before in the Senate, which is fine. We know we have some good people to work with. We were doing well in the House. And so we're just waiting to see which way our lobbyist wants us to go. And but we already have the bill. We know we're going to use the bill with all the amendments we ended with last year. So we're going to pick up where we left off, and that should save some time. Next. Yeah, I just covered some of this. We've stayed in contact with who our expert testimony is. One of the people who testified, our expert testimony, was Marlon Hoover, also Morgan Friedman, and Ruth Rowe Navardi. We had 3 prescribing psychologists testify, all 3 of which have trained medical school students in psychopharmacology. So at the point where you're training, psychologists are training med school students, that's a pretty solid argument that apparently we have some competence. Next. So the science prereqs, this is what they are. There's a grandfather period. This is some language that Michael came up with. And there's general biology, chemistry, biochem, microbiology, human physiology, and human anatomy. It all comes to 270 hours or 6 courses, assuming 3 hours each. Next. Okay, were these needed? Well, I'm going to tell you, only one state has them, which is Illinois. Iowa, Louisiana, New Mexico, Idaho, the Army, Navy, Air Force, National Health Services, and Indian Health Services don't require them, and they've all functioned well. The people who completed the Alliant program did it without prereqs. However, arguments for it. The lack of science background may be an issue with some of the people who didn't complete it. Our bill had not moved in 8 months. We had had it introduced in August, and it was March before we had a hearing because the opposition was kind of beating up on us so much by saying we didn't have enough training. Kind of like saying your dissertation isn't heavy enough, which some of you guys haven't gotten to yet, but you may get that. And so once we added these courses, suddenly we had 6 hearings in 3 months, and we had more activity in those 3 months than in any period since we've been working on it. Interestingly, APA is looking at adding science prerequisites, as are some programs. So some of this is coming. Maybe not as many as we added, but it's coming. Next slide. Current programs, Alliant International University, San Diego, that's the California School of Professional Psychology. Fairleigh Dickinson, that's in New Jersey. In the Chicago School of Professional Psychology, that's one I work with a little bit as an advisor. The University of Findlay is a future program. We're going to talk about that in depth. University of Hawaii at Hilo, it was there, and the legislature, they did something to shut it down, and it's going to be restarting. New Mexico State University has one that's restarting. In basically any state that passes a prescribing bill, you're going to see a program pop up. I just saw a notification that there's one starting up in Idaho. Next. So this is the University of Findlay's program. I'm not going to read everything here for you, but I just want you to have it and see it. The University of Findlay, thanks to the work of Dr. Strauss, they have a program ready to go as soon as we pass a bill. And in fact, they came down and testified. Next. And this is some additional stuff, how it's laid out. Next. This is here for you guys to see. I don't need to read it all to you. Next. Okay. Next. And here's the stuff for supervised experience. And this is where we get into something interesting. Okay, they have their stuff to explain the supervised experience. Next slide. Okay, so one of the arguments we've made is that there's a shortage in Ohio, and primarily in rural areas. Our colleagues on the other side of the aisle have said, oh, you guys won't do that. Well, there's research that shows only 43% of psychiatrists take Medicaid, and 90% of prescribing psychologists take it. So we've found that we do help people more in other areas. And to boost our argument, the University of Findlay has training hubs set out throughout the state, okay? And if you look, half of these are set up in rural areas. So their program is designed to teach people originally in pharmacology to be able to work in rural communities. They also teach physician assistants, and they're plugging in our master's program into their existing training hubs. They pay the people who provide the training a nominal fee to kind of facilitate it. And so there's these various sites that any of us could do around the state once we go through the program. And it's a really neat asset, and it's going to help people get the clinical experience they need. Next. Here's the supervision requirements. They're in the bill. Again, I'm not going to read them all. It says you must have 1 year. We have to see at least 100 patients. You can read all the detail later. Next. When you're going through supervision, it's the physician who has the responsibility for issuing any prescriptions, because initially while you're getting supervised and training, you're not certified to do it. But what'll happen under the way the bill's written is then once you do get certified, if you haven't finished your science prereqs, you would get a conditional certification, and then you've got 5 years to finish those science prereqs. And then you would get your full certification. By the 6th year after the bill passed, the way it was written, you're supposed to have your science prereqs before you start. So anyone who who's ready to kind of jump into this when the bill passes, you don't have to have all those science prereqs done up front. Again, that's part of the language that Michael crafted. I thought it was a wise idea that he came up with. Next. Clinical competencies. There's a list of what the competencies are we're supposed to have that's in the legislation. My expert opinion, you have something I can't pronounce. Yep, you're going to run into a lot of medical terminology. It's okay, it's manageable. There's a nice little software program that you can get on your computer that helps you with medical terms. I use it, and the people will tell you what it is. Next. There's this additional amendment. They were going to take working with children, people on age 18 and under, under 18, out of the bill because they thought it made it too volatile. And I talked to the committee chair and I said, gee, that's the most underserved area. So he asked us to come up with some language. This accepted this language was an emergency room physician who was chair of the committee. And you know, it was Michael's idea that we make it 6 months, which would be 1,000 hours supervised clinical experience. So through supervision, you have to get experience under a family practitioner, a pediatrician, or a child psychologist, or sorry, psychiatrist. And then when you're collaborating, you would have to be in a collaborative relationship with one of those three, a family practitioner, a pediatrician, or a child psychiatrist. So it provided an avenue for us to really be there for this underserved population, most of which is getting treated by family practitioners, probably 80% of it. And there's nationwide, there is a shortage in probably 47 or 48 states that's critical for child psychiatry. So we really hope our bill can help there, and we really hope some of you people who are specializing in kids can help there in the future. Next. This is just some of the language on collaborative agreements, so I just want you to know it's there. Again, you can look at it later. I just want you to know I put it in here for you to look at, and that's it. And let me look at my watch. We've got time for questions for everybody. Let me turn it back over to our moderator.
Good morning. I'll be interested in knowing how much time I should take. I'm not sure how long this is to last, but I want to talk with you about what it's like to be a prescribing psychologist. Next slide, please. I think to become a psychologist, there are several fundamental motivations. The first is empathy for people. That motivates us to become psychologists, to assist people to alleviate suffering. The second, efficacy. We want to be effective. We want to make a difference in people's lives. Curiosity. We wonder what makes somebody's psychological functioning happen. What are the forces that affect psychological functioning and people's psychological states? And then finally, professional status. You as students are undergoing all this specialized training because you want to end up with a profession, with an ability to do something and to do something that alleviates suffering, effective, satisfies your own curiosity, and also provides an opportunity to make a living. Training to be a psychologist satisfies all of those primary motives. Actually, becoming a prescribing psychologist enhances your ability to act on those primary motives. We see people suffering because there are barriers to the availability of psychotropics. And there's barriers to people getting timely adjustments in psychotropic medications. And we're sitting there watching people suffering without a means to directly alleviate the suffering that could be alleviated if they had access to psychotropic medications. And in fact, watching somebody suffer without being able to do something effective about that is one of the reasons there's clinician burnout. It's very difficult to witness people suffering without being able to do something to alleviate that suffering. Becoming a prescribing psychologist then allows you to become more effective because you can intervene not only psychotherapeutically, but you can also intervene with medications, with starting or stopping or adjusting medications. So you can function more effectively, more directly in treating patients if you in fact have prescriptive authority to manage patients. And becoming a prescribing psychologist also is a way to satisfy your curiosity. You become very knowledgeable about psychological functioning in a doctoral program in clinical psychology. You learn some about the biological basis of behavior, but you don't really learn as much about the biological foundations of behavior as you do if you are becoming a prescribing psychologist. The additional study of the biological sciences and of neuroscience satisfies that intellectual curiosity, in addition to making it possible for you to be more effective and to alleviate suffering more effectively. And then with regard to professional status, certainly as a psychologist, you're going to have a professional career. You get compensated for your services. There are many opportunities and roles that you're going to be able to apply for or experience if you're a licensed clinical psychologist. And psychologists have a very high level of trust by the public, that studies have shown that among the professions, psychologists, the trust of psychologists is quite high among professions. As a prescribing psychologist, you have enhanced professional career opportunities. There's a modest increase in compensation. There are additional opportunities and roles. And especially when you're interfacing with medical providers of all kinds, there's enhanced trust of you because of your medical training in addition to the psychological training. I would say one of the things that is interesting about being a prescribing psychologist is, in fact, that you have an opportunity to collaborate more effectively with medical providers. Following my getting prescriptive authority 11 years ago, I ended up teaching in a family medicine residency, teaching resident physicians to manage psychotropic medications and also to provide behavioral interventions and trying to enable them to rely less on psychotropic medications and more on integrated behavioral services in an integrated primary care setting as well as in a general hospital, where I had prescriptive authority in all units of the hospital, including the intensive care unit, and was able to work with physicians and with advanced practice nurses and other medical personnel in all of those units. So there are enhanced opportunities that come with becoming a prescribing psychologist. So what do I like to do most as a prescribing psychologist? I found being a non-prescribing psychologist very satisfying and meaningful. And it's entirely possible to be a very effective provider of psychological services without having prescriptive authority. However, what I like to do most is to take people off of inappropriate medications. I spend more time taking patients off of medications than I do putting them on. Another thing that I like to see, though, is when I do prescribe for a patient, I like to see the measurable improvement that comes in the patient's improved quality of life. Now, bear in mind that only a subset of patients needing psychological services need medication. So we're not talking about all patients. We're talking about appropriate patients and those patients for whom combining behavioral or psychological and psychotropic medications is most effective. And then it's fun to see that there's enhanced efficacy by providing both the behavioral and the psychotropic medication at the same time. And I thoroughly enjoy providing the combined psychotherapeutic and psychopharmacologic interventions with patients. What do I not like about being a prescribing psychologist? Well, for one thing, I don't like the fact that all medications have the potential for adverse effects. They all have side effects. And all side effects are effects that are not wanted. They're not what we want. They're not what we're trying to do. And all medications have those. So I don't like the fact, I don't like the reality that medications have side effects and some potential for adverse effects. Another thing I don't like is the frustration that comes from how long it takes, how much you have to be on the phone to get prior authorizations for medications. There is additional paperwork, additional phone work that comes with being a medical provider that you don't have as much of as a non-medical clinical psychologist. You may still have to get prior authorizations, but it's clear that many insurance companies have a preferred list of medications which are cheaper, and oftentimes they may have the potential for more side effects than the more expensive and newer psychotropics, though that's not necessarily true. And serving a population in New Mexico, I often have to prescribe with old psychotropic medications because that's all that can be available to the patient, because that's all that they can afford. And then the other thing I don't like very much about being a prescribing psychologist is getting hostile reactions from opponents of prescribing psychology. I'm sort of a quote-unquote hired gun, meaning I think Dr. Potts mentioned that I came in and testified in the Ohio legislature, and I've done that in other states that are pursuing prescriptive authority. And I do it, but I don't like being framed or accused of being a dangerous person who is a danger to the public by opponents of prescribing psychology. And although a majority of clinical psychologists are in favor of prescriptive authority for psychologists, we still have a small minority who are in great opposition to prescribing psychology. And so that comes with the territory of being one of the first prescribing psychologists outside the military, and then actually trying to advance prescriptive authority in other states. So I'm wanting to leave time for questions, and so I will stop now, because I think we're about out of time, and see if there's time for questions.
So we have about time for 2 or 3 questions, and other questions that people have can be directed to the speaker's emails, which are at the beginning of the slideshow. But one question that I had is about your understanding of the opposition's views on opposing legislation that would support prescriptive privileges. So obviously, all of us here likely see a lot more compelling reasons to be pro-prescriptive privileges than anti. But what are some foreseeable drawbacks that you anticipate if this legislation were to pass in Ohio or in states where legislation has already passed?
There are principally 2. And let's say from the medical community who are not familiar with the training, and from the general public, the question is the training adequate so that the prescribing psychologist can prescribe at the same level of safety of very proficient medical personnel who are managing the same medication. So the first is that safety issue, and it's a legitimate question. Now, I think we've answered that question satisfactorily because of the history of safe prescribing. But then within the psychological community, the concern is that it's going to medicalize and actually create even a two-tiered psychological profession, with the possibility of there being a hierarchy with prescribing psychologists being considered more proficient than non-prescribing psychologists. And that's behind some of the opposition, is letting the medical community into psychology and reducing the status of non-medically trained psychologists.
If I could add something to that, Marlon. Well, if you look, there's a trend line. One of the trend lines in the country is prescriptions for psychotropic medications are up. The trend line's going like this. The trend line for therapy is like this. All right. So what you find is people are doing less therapy because their insurance and all this other stuff. My hope, and the way the training is set up, is what you find is for any severe condition, combining psychopharmacology and therapy tends to be the best outcome. And my hope is that with more psychologists being involved, more people will be getting directed to therapy, because we're versed in both of them. We understand them both very well. And we will also not be putting people on excessive amounts of medication, like Marlon said, that you end up taking people off. So I think we have the ability to provide, to re-emphasize therapy. And in fact, a lot of my training and what I've used it for so far is to make people realize what you can do with therapy and not overestimate the medications.
If I can add to that as well, I've gone through this merry-go-round in my previous career. So when I was credentialed as a surgical physician's assistant back in 1975, medicine was dead set against it. And the only reason PAs came into being was because there were a lot of field experienced medics coming back from Vietnam. So when I started practicing, I would write orders in the chart and nurses would refuse to follow them. So it's not unusual that early in one's career, if it's a new aspect of extensions of professional practice, that you're going to get some blowback. But we work through it, and physicians these days, physicians' assistants are well respected these days. And as a matter of fact, my wife and I took my mother-in-law to the emergency room last night, and it was a physician's assistant that took care of the entire process and got her admitted to the hospital. So early on, there's going to be hiccups, there's going to be resistance, there's going to be resentment. But as time goes on, prescribing psychologists are going to be just part of the mainstream. So you may be adventurous and think about getting in on early in this aspect of your profession. But I think in the long run, it's going to be perfectly fine.
Great, thank you so much. Another question, and this is coming from Xavier students. Has there been consideration of continuing education requirements? Would it be manageable to complete the requirements to continue to be a licensed psychologist in addition to the RxP continuing education?
And yes, I would like to ask the Xavier people to turn on their camera. I heard there's 14 people there and we want to see them. But yes, there is CEUs required in the bill. Jerry, do you remember the specific number? Or Michael might remember. It was 20 or 30?
I think it was an additional 20.
Okay, on top of what we're required to do already as psychologists.
Correct.
And the funny thing is, guys, if you look at psychologists compared to counselors, social workers, and everyone else, we actually are required to do less hours than other professions. So the fact that we have 20 more for RxP, I usually have double the number of hours I need anyways. I get lots of CEUs. But yeah, it's built in the bill. And of course, you were going to have that specifically for psychopharm. Absolutely.
I have a question regarding graduate programs like in the future. Do you foresee graduate programs having prescription training as part of their curriculum instead of having to do it as a separate degree? And what do you see as the advantages or disadvantages to this?
The new APA's model curriculum includes the opportunity for schools to do a lot of the foundational courses during the doctoral program, so that the actual training in selecting medications and applying those would happen postdoctorally, but a lot of the foundational courses up and including physical assessment and learning how to do physicals could happen during a doctoral program. So schools could choose to incorporate that into their doctoral programs as a track, and that may happen in the future. You do need to understand, though, that some of the greatest resistance to prescribing psychology is from the old guard academic clinical psychology faculty who are not prescribing psychologists and who oppose the inclusion of medical training into doctoral programs in psychology.
The way the bill's set up, they're doing that in Illinois, and I go over there every 6 months and we talk about these things. There's nothing in our bill to prohibit it. It seems to be that it's not just, Marlon makes a really good point, it's not just the faculty, the psychology faculty, it's also the faculty, whatever other program's going to offer it. So where are you going to get the training in another school? Is it going to be coming from their pharmacology program? Okay. Well, there's 6 in the state, so they're not going to be at every place where there's a PhD or PsyD program. Is it going to be through the nursing school? You know, so there's those kind of logistics. Now, certainly Finley's entrepreneurial enough that they could enter into some kind of joint agreements with PhD programs where they do some hybrid model, and down the road maybe that's possible. The downside is that the concern is that people need to have a sense and a good solid foundation in the practice of psychology. And psychotherapy is a very solid, powerful thing to do. And the therapeutic relationship is the most powerful thing also in psychopharmacology. If you don't have a good therapeutic relationship with your patient, it's going to really undermine what you're able to do either with psychopharmacology or with psychotherapy.
Yeah, I'd have to agree with Brad on that it's important to learn how to become a psychologist first. I have no problem with graduate students taking other basic science courses, and that tends to balance things out nicely, but it's a matter of time. Do you have the time to take those other courses as you're going through graduate school? I think some people would say yes, I can handle both. Others will say no. But I think it's important to have that foundation of being a psychologist, thinking like a psychologist, and then add the pharmacology part afterwards.
We realize some hybrid models will probably develop in the future. And as to the prerequisites, it's a problem for the current generation. Future generations will have factored that in to their education. Much of what Jerry and Marlon and I are doing is really not going to be stuff that we benefit from. It's really going to fall to you guys. This is something that's really done for the future of psychology, for the future of the people we're treating, because in the future, there's less and less psychiatrists and people can't find treatment. There's a high percentage of these people who are over 65 already and are retiring. And the shortage is so severe that I think our opposition is actually running short on funds. They have 1.5 staff people. They've given up their own lobbyist. They had trouble putting up people to lobby against us. We need to have some people there to treat the public.
Thank you. It looks like we have another question from Allie. If moving to a state that does not have groundwork for prescriptive authority, do you recommend obtaining a master's degree in clinical psychopharmacology, and I assume not being able to practice, or would it be advantageous to obtain a degree such as a psychiatric NP so that we can prescribe while also advocating for prescriptive authority?
Let me say that it's important to remember that there are military installations in a lot of states that don't have prescriptive authority, and a prescribing psychologist can prescribe if they're in the military or in the Indian Health Service. And there are a number of states that have reservations and outposts of the Indian Health Service that would permit a prescribing psychologist to prescribe. So it is possible to prescribe even in states that don't have prescriptive authority written into their law. The problem with going the nurse practitioner route, and there have been some people who have done that, is that really does redirect you out of the psychology house and into the medical house. And advanced nurse practitioners tend to model what's done in psychiatry. And we are trying very hard as prescribing psychologists to learn what we can that is valuable from our psychiatric colleagues, but to keep the focus on psychotherapeutic services and to remember that much of what people need is not pharmacology. And the advanced practice nurses often don't have as much training in psychotherapy as do certainly psychologists. So it's sort of a professional redirection if you go that way.
If I could also add, in Ohio, actually, I can already consult on psychopharmacology under state law as long as I'm qualified. And there's even some insurance companies that may reimburse for that. But you really need to know the nuances of whatever state you're going to, because in Ohio, to be a nurse practitioner, first you have to be an RN. So that's not as easy a chore as you might think. Also, there's this issue of a nurse practitioner program or a physician assistant program is going to train you to be a generalist. A master's in clinical psychopharm is going to train you to be a specialist. This came up in the hearings, and Jerry did an interesting table where he compared 2 physician assistant programs to our Master's of Science in Clinical Psychopharm from Alliant. And what we found was that the Master's in the physician assistant degree had 10 to 15 hours of mental health, but the Master's in Clinical Psychopharm had 192 hours of training in mental health. Now, this is really ironic because what was happening is the opposition was arguing our training was insufficient. We needed to be physician assistants instead. But when we actually looked at it, broke it apart and did the math, our training better prepares us and has more training. And in fact, they were arguing against their arguments were contradicting each other because of that. So, just there's things to consider. If you were already a nurse before you became a psychologist, I could see it. I could see it's an easy path. I could see that would work for you. And I have a friend like that. If you're not, I would really take a look at state laws wherever you're going, because every state has nuances.
To dovetail again with Marlon's point, another agency you might look at, and all states, I believe all states will have this, is federally qualified health centers that will hire psychologists, prescribing psychologists, and allow them to prescribe in those centers. So you've got a number of different options in states that may not have introduced a bill yet.
And by the way, the FQHCs, with Dr. Strauss just mentioned, you get your school loans for becoming a psychologist paid off by serving in an FQHC.
Yes. Yeah, they can pay so much, and there's 106 federally certified shortage areas in the state of Ohio, 26 of them in the Department of Corrections. I would want to say one other thing to everybody out there. You know, we're about to start this process again, and I would really love to have all you guys, I assume you're OPA members, that you've gotten that student membership, which is free or really cheap, and that you guys could get on the RxP listserv, which OPA has, and we keep you informed of things, because I would love to have you guys tell me where you're at, what cities you're from, and be part of our network, our grassroots network, to help on legislation. We want to reach out to people in their home districts. We have a lobbyist that talks to them in Columbus, but having someone who meets with them in their district, or someone who's a constituent from their district, that makes them listen to our lobbyists more. And it's huge, the impact. We'd love to have you guys get involved.
Great, thank you so much. Does anybody else have any questions?
May I make one more comment?
Absolutely.
And that is, as I know, if you're already in a doctoral program and you're buried with work, the thought of adding more years of classwork and training, that may not seem so attractive to you right now. But it is doable, and I think most of the people who've completed the training are very, very thrilled with what they've learned and the doors that it has opened up for them. And trust me that at some point you will feel like taking more classes. You will want to satisfy your curiosity. You will want to expand and enhance your skills.
And I want to wish everybody good luck on finishing your programs, finishing your dissertations, doing your APA internships, and passing your EPPP, which I know is really the first priority for everybody. And I think you guys are going to do fine. Anybody who shows the initiative to look at this, you're going to be doing well. Here's another question. As you stated, you're advocating for future generations. As you advocate for these future generations of psychologists, will you also be advocating for them to receive similar benefits to other medical professions, like neighboring programs? There is a bill in Congress for physicians to be designated, psychologists to be designated as physicians, the way every other doctoral level profession is, and that would open them up to get some of these other benefits you're asking about. So that's happening through our national advocacy. David Hayes is your person at OPA who's doing that. Jerry, you know something about that, right? Because Sherrod Brown, our state senator, U.S. senator, is the guy carrying the bill, isn't he?
I believe so. And this started, oh man, probably 4 years ago, I think, maybe even longer. But it's like many things in legislation, it takes its time. But I think with more allies in the House these days, it may shift to the House. I'm not sure on that side who the sponsor or co-sponsors would be. But yes, you're right, Sherrod Brown had it in the Senate, but it may shift to the House for the time being. But that's APA pushing that out. I haven't spoken with them recently about where it stands and what kind of support it's garnering. I can find out though.
Yeah. You know, from the political point of view, I think we've won the argument on the science and the effectiveness. I mean, one of the things we use that Marlon shared in terms of safety is the insurance premium that people pay to be a prescribing psychologist is $135 more a year. Now, insurance actuaries don't care who wins this battle, and that's something we've used with legislatures. They just care about the numbers, and that's where they put the risk on top of what your other liability insurance is. And the science argument, I think we've won. The politics is the thing we're going to have to fight. And the opposition is using the same argument they used against physician assistants and nurse practitioners. And that's actually backfiring on them now because people have kind of gotten tired of them singing the chorus. And what you find is now we can come back and say, gee, you said that about nurse practitioners too. And gee, here's the research. And it says, in fact, they actually do a pretty good job. And in some indicators, they do better than physicians. So how are you so certain about this with psychologists? And in fact, one of the joint sponsors who was co-chair of the health committee was questioning the opposition on that exact same line of thinking during the hearings. So we really are in a stronger position than we've ever been. I really like where we're at. We've been fighting a good battle, and it's people like Marlon coming, it's people like Morgan Salmon coming, it's Ruth Rowe Navardi out of RAPAT, it's Jerry testifying. We've been fighting a really good battle on this. I feel good about it.
If you had to put a timeline on it, when do you think, how many years do you think it would be before it passed?
No one could do that. That's just not the way the world works. We've been working at it 10 years. What you have to understand, yeah, if you've been around the legislature, you have to understand that when people see something's been around that long, to them that means something. Hey, this is about time for this to pass. We've done this long enough. We've looked at it. This idea it has staying power. That actually works in our favor. We're starting the beginning of a 2-year legislative cycle. We have a polished bill that we spent a lot of time in the last cycle developing. I retire at the end of this 2-year cycle. I'm free to continue doing this without anything else distracting me. I want to see it pass in this 2-year cycle. If not, I want to see it pass in the next. But I believe it's going to pass, but no one can make promises. That would be dishonest of me to say that.
It has passed in 3 states recently.
Yes.
And those are Illinois, Iowa, and Idaho.
It got to the governor's office in Oregon, was vetoed. It's gotten to the governor twice in Hawaii and was vetoed. Hawaii has 3 bills right now. It's in the legislature in Florida right now. I lose track of Texas and some of these others. Kentucky, I think, is doing a bill right now.
Yeah, I heard that.
Yeah. Randy, who else is working on one right now?
Well, I think Texas is working on a bill now too.
Yeah.
Well,
But
thank you.
Also Nebraska. Go ahead.
Oh, Nebraska.
Thank you all for your questions, and especially to our speakers, Dr. Strauss, Dr. Hoover, and Dr. Potts. We really just appreciate you sharing your perspective and allowing us to just continue to ask you questions about what you all are passionate about. So thank you all attendees as well. And again, if you have further questions for the speakers, their emails are at the beginning of the slideshow.
Thank you.
Thank you all. Appreciate it.
Thanks for having us, guys. And again, join the OPA listserv, or the RxP listserv. You can write back at Karen. Come and join and help us work on this. We'd love to have you. We can work it around your summer schedules or when you have time off, or or just writing a letter. We can make it simple and manageable. But we would love to have you as part of this. Thank you.
Take care.
Thank you.
Thank you.
Bye-bye.
Bye, everybody.
Thank you. Bye.